Good morning, I'm Meera Sivasothy, and I'm your guest host in this antimicrobial resistant talks, or in short, AMR Talks. It is about bridging gaps and sharing solutions. This podcast is an initiative by AMR Research and Work on Innovation and Sustainable Solutions Research, also known as AMR WISE Research Group from University Malaya. Our aim is to increase awareness about antimicrobial resistance. Now, according to the WHO, antimicrobial resistance poses a global threat, and it is now referred to as the silent pandemic. The main cause of AMR is the overuse and misuse of antibiotics in clinical care. If left unchecked, AMR has the potential to kill more people than cancer, traffic accidents, and even HIV. So it affects people of all ages, races, and in all parts of the world. Joining me to shed more light on this is Anton Peleg, Professor of Infectious Diseases and Microbiology, Director of the Department of Infectious Diseases and at the Alfred Hospital and Monash University, also founding member of the Monash Center to Impact AMR, launched early 2020. Welcome to the show, AMR. Welcome to the show, Anton.
That's right. You can call me AMR for the rest of the interview. That's very fine. So, thank you.
I have it coming out of my ears, Anton.
Yeah, I know you. AMR, every second word. So there you go. It's good.
It is good, but I have to say it's just between very few of us who understand the potential threat that AMR actually has on the rest of the world, Anton.
Yes.
Tell me how, I wish more, and we hope after this conversation, more people will start talking about AMR and the threats and
absolutely.
how serious it actually is.
Yep.
Anton, you want to share that personal journey with me on how you actually decided to go into this area? I mean, infectious disease is very wide. Why AMR?
Yeah. So as actually one of the most sort of striking moments during my infectious diseases training was I was called to see a patient on a ward, on the hematology oncology ward, so a patient whose immune system was very suppressed. And I went to see her on the ward. She was extremely unwell with high fevers and shaking and extremely unwell. And we took some blood cultures to see if she was, what she was infected with, and started broad spectrum antibiotics to try and to treat her. And unfortunately, she passed away overnight. So within probably 6 hours of me seeing her, she passed away. And I was a young trainee in infectious diseases. So this was emotionally very upsetting. And then what happened was a day or 2 days after she had passed away, the cultures that we took from her blood were positive. And not only were they were positive with a bacteria that was resistant to all of our traditional antibiotics. So at that point, it didn't matter probably what we were going to treat her with. She was infected with a bacteria that was pan-drug resistant to everything that we've got. And I think that was a striking moment for me to say, wow, this is a real problem. And I want to dedicate a good part of my career to try to understand how this has happened, what are the drivers, and most importantly, are there new solutions that we can come up with to try to prevent what I've just seen in this patient.
But what's brought us here, Anton? I mean, we know there's misuse of antibiotics, the overuse of antibiotics, but from what I understand, the last time we even came up with an antibiotic was decades ago. What's happened? Why has it been so difficult to come up with a new antibiotic to help with these strains?
Yeah, so I think there's a lot in that question, and it's about why is antibiotic resistance with us? Like, why is this a problem? And then the next thing is, the other part of that question is, why is it getting harder and harder to develop new antibiotics? But let's just start with that first part. And I think that there's no single reason or single driver. This is a multitude of drivers. And I think we need to really have an understanding and appreciation of how smart bacteria are. So bacteria evolve. They want to survive like other things want to survive, and they adapt and rapidly develop mechanisms to prevent them from being killed, whether that's an antibiotic or an immune system or something in the environment. And so there are natural evolutionary drivers within bacteria that are always going to make them evolve and adapt. And then it's a bit of a sort of arms race between the bacteria and the humans and how we're understanding and who's one step ahead. In terms of what's driving it, there are selection pressures, like you say, about antibiotic use. And that's, when we think about antibiotics exposure, we think about exposure in humans, but we also have to think about the huge load of antibiotics in the agriculture and animal industries. I think if you look at the actual tonnage of antibiotics used, it's exponentially higher in non-human use than human. So I think they're key factors. Then you have other factors like human movement and travel. You know, if you look at the amount of human travel there is now, it is quite phenomenal. And we know that these resistant bacteria are carried in the gastrointestinal tracts of humans. And you know, when someone comes to a new place, they probably come colonized with the bacteria of that new country or new city within probably 3 to 5 days, I would say. And then they can then go back to their countries. And so humans are acting like vehicles to transmit this around the world as well.
Like a catalyst.
A catalyst. And then sometimes they get admitted to different hospitals. And so you can imagine there's a real ability to transmit this very quickly. Obviously, there's a whole lot of other social and government and regulatory aspects around antibiotic resistance. There's a very fascinating article out of a group from Australia that looked at the correlation of sort of government regulation and actually corruption and how that relates to antibiotic resistance in that country. And it was quite interesting. It was quite a correlation between the level of expected or estimated corruption and antibiotic resistance. And that probably is a measure or marker, of regulation around antibiotic use. So, you know, over-the-counter antibiotic use without scripts, training of healthcare staff and providers, access, use of antimicrobials in agriculture. You know, the regulation is probably really important, and that probably is a surrogate marker around corruption, etc.
Sure.
But I think that, you know, that's just to highlight just a few of probably some of these big drivers. The second part of your question is also really interesting. So 1940s penicillin, and then we went through decades of, you know, an era of many new antimicrobials. What has happened is that we have antimicrobials work by targeting different parts of a bacterial cell. And now we're at a point where we've got antibiotics that target almost all of the parts of a bacterial cell already. We've almost saturated our targets, our more traditional targets. And so it's getting harder and harder to develop completely new novel antibiotics because there is already so many that we've tapped the system so hard that there aren't too many new targets left. However, in the last, you know, I'd say 5 to 10 years, there's more emphasis on trying to identify the targets. So the basic microbiology needs to be done so that we can understand new targets, but it is getting harder, and that's why completely novel antimicrobials are less and less on the market. The other thing I have to say, again, giving credit to the bacteria.
Really?
As in just the appreciation of, and we should realise how smart they are.
I call them
it's more respect than what I'm trying to say. We need to really respect them, and by having that level of respect, gives us a mindset that we have to be very careful with what we do. We're not dealing with something silly. We're dealing with something extremely challenging and smart and adaptable. And even when what my point is even when we've developed completely new engineered molecules, often the bacteria very quickly can already develop resistance to a completely new human engineered molecule, because there's often similarities to some other molecule that the bacteria has seen through evolution,
Right.
and they may have mechanisms inherent that cross-react with this new molecule.
Right.
So there's examples of that already. So I think when I use the words respect and etc., it's more just we need to be going into this as a very tough battle. This is not an easy thing to blow over.
Would you say it's industry and government-wise, would you say this is a market failure? And the reason I ask you is because, if you compare that to viruses, maybe we can talk about that. I mean, we've come up, when there's been a will, we saw that with the COVID pandemic, we came up with vaccines really quickly. That is because the situation was dire. There was funding. Do you think we will end up coming to that sort of dire situation before we actually take this seriously and start moving faster?
Yeah, I think that. I think you're right that there's a less appreciation of the significance of AMR, but I think now governments are starting to realise. As you've mentioned, the WHO. Last year, there was a very important paper that we were thankfully able to be part of in the Lancet that looked at the global burden of AMR. And it estimated that just under 5 million people died of an AMR bacterial infection in 2019, which probably puts it up at the sort of third leading cause of death. So that appreciation is now starting to happen through governments. The tricky part is that's different to viruses is the biology and the science is different. And coming up with vaccines to prevent some of these bacteria, like these superbugs, has been very, very challenging. Probably more so than targeting vaccines for certain viruses. But I do think that with increasing resource and investment, I think there's a lot of really exciting opportunities coming through. I'm more optimistic now that there's government awareness. Funding agencies around the world now have put AMR as in their priority lists. And so I'm more optimistic that there are resources to come to support the fundamental knowledge that then can translate to some of these great new therapeutics and preventative vaccines.
You were involved with helping manage COVID-19 in the state of Victoria.
Yes.
Did you see an interplay between COVID and AMR? Because for people who then had severe disease, then
yes,
that's where I can imagine antibiotics or AMR becomes a problem as well. Did you see that happening?
Yeah, we definitely saw our use of antibacterials in people with moderate to severe COVID coming into our hospital, increasing substantially. The other thing is people with severe COVID often went to our intensive care unit and would actually have quite long length of stays. So we had, a big portion of our intensive care unit was filled with patients on artificial lungs. They could stay in it for a long time with devices in, tubes, plastic catheters, and they became very heavily colonised or carriers of antibiotic-resistant bacteria, and then subsequent developed often infections. So we definitely saw an increase in antibacterial use because it was a concern. You had someone who was very sick. Sure, they had COVID, but we knew that there were secondary bacterial infections. And I think worldwide there's been descriptions of the impact of COVID on AMR, some saying not that much different. Others giving examples where there was increase in AMR. So I think there are all of these sort of new drivers that are always coming at us, where we have to think about our optimal use of antibacterials, and that's where that whole concept of antimicrobial stewardship comes into it.
Yes. So let's talk about antimicrobial stewardship. What do you actually mean by antimicrobial stewardship, and who is responsible for this?
Yeah, it's an interesting word. It's probably not the best terminology.
I wouldn't know.
I think that I think that for us in the space of antimicrobial resistance or superbug infections, I think we have to work out our terminology, and this is a good example. Even antimicrobial resistance is a bit of a mouthful.
It is.
And it's not very tangible for the greater community to be able to grasp.
Before we come back to stewardship,
Yes.
We use antimicrobial resistance interchangeably with antibiotic resistance. That's not right either.
That's exactly right. We've got different words. We all use different things.
I mean, to the layperson, antibiotics is something they relate to much easier.
Yes.
Yeah, but it's not the same thing. Or it is part of it.
It's part of it. That's right. So stewardship is not an amazing word, but basically what that whole area is how do we support the best use of antibiotics in a way that, of course, antibiotics are needed for infection. We need to use antibiotics, but how do we use the most appropriate antibiotics for the patient in front of us with the condition that they've got for the shortest time of the narrowest spectrum? How do we optimise the existing antibiotics we have so that we don't burn through them more quickly? And that's, I guess, broadly what we put on as what we term this antibiotic stewardship. Often hospitals will have teams or committees dedicated to this. They can work in all different ways, and that is often a challenge because there's often this conflict between a sick patient in front of you, and obviously you want to get them better. And that might include antibiotics, and you might not know what the infection is due to. And so, maybe broad spectrum antibiotics are used. And so there's a conflict between the patient in front of you versus what are the consequences of my antibiotic choices on the broader community.
So the definition I have here is stewardship means understanding how to choose the right drug for the right bug, for the right duration, in the right scenario, and for the right reasons. That'd be right.
Exactly.
Okay. And so who should be the face of AMR?
The face of AMR or the face of stewardship, you mean?
Stewardship, both.
Yeah.
I mean,
So
because AMR is not something that you relate to very easily.
No,
right?
no. I mean, I think what we need to get to is that AMR is something that needs to be inherent in all parts of medicine and healthcare, rather than saying that one group is the face or ownership of it. I think there needs to be inherent understanding across all subspecialty areas and all parts of healthcare, because we need to all own it. And I think that's probably, we're not there at this point. But it is something that we, at least at our institution, do try. So, for example, our committees related to infection prevention in the hospital, to prevent hospital or healthcare associated infections, we make sure we have representation from all parts of the hospital, including the executive, surgery, anaesthetists, parts of medicine, and really have an engaged group that feel like they own the problem. And I think that's where we've really tried to move toward, and I think that's an important way forward.
Okay. So if it cuts across all races, all ages, people in geographically, all over the world, right? What is the gold standard for detecting AMR? What is the gold standard at the moment?
Yeah, for detection. So the current most common method is obviously someone takes a culture of some sort of sample, and that might be a human sample from fluids or tissue or sputum or urine or blood, and then that is sent to a microbiology lab. And a microbiology lab, most commonly around the world, will set up culture on media and will grow what bacteria are growing. Once the bacteria is grown, which can take 1 to a few days depending on the bacteria, sometimes even longer, then they will take the colonies that have grown, the bacteria that have grown on that plate, and then they'll do testing under different antibiotics to see whether it grows or doesn't grow. And that will tell you whether it's sensitive or resistant to the different antibiotics. That can then take, again, another couple of days. So you can imagine that someone who's very sick with, let's say, bacteria in their blood, we might not know the bacteria, what it actually is in the blood for a day or two. Then you might not know the susceptibility, whether it's sensitive or resistant to the antibiotics for another day or two. That's already 2, 3, 4 days down the track. That's too long. So we need new methods to speed up the ideal way to detect AMR. And there are now a lot of new ideas, new tools that are coming out. But I think what's important for these new tools, which are often molecular tests and rapid diagnostics, is that we have to be really conscious that these are tests that are developed that are accessible around the world, not just to resource-rich reference laboratories, for example. So it's about equity and accessibility, and I think that's where that next frontier of the diagnostics of AMR is really important.
Okay. We'll come to the good work you're done with the Superbug AI flagship project. But before that, the Alfred Hospital in Melbourne has become the first health service in Victoria to begin using the pioneering phage therapy. And this, from what I understand, is using genetically engineered viruses which divide inside a bacteria and then subsequently destroying the bacteria. And this therapy has, goes back time immemorial. I mean, even before. It was a therapy that was used before antibiotics actually came to be.
Correct.
I mean, we've become so desperate that we've actually gone back to phage therapy. Now, why is it the first health service in Victoria to begin this? Because if it's been there, what's different about it now?
Yeah. So I'll just give you a little bit of background that bacteriophage are, interestingly, small viruses that that specifically attack bacteria. So unlike COVID and other respiratory viruses that everyone knows about that impact human cells, these are viruses that just target bacteria, which is a pretty exciting, interesting thing to think about. And when I was saying before that we are looking for new ways to attack bacteria, well, this is a potential, it's been around for a long time, but now we understand the science a lot more. So phage were, first identified, in the late 1800s, early 1900s. They originally, it wasn't known what they were, but there was like river water in the Ganges River that was shown to have activity against certain bacteria, and it seemed that people who lived and drank some of that water got less gastrointestinal tract infections.
Right.
And they were like, why is this happening? And it wasn't until sort of, early 1900s it was realised that these are small viruses, and they called them phage. The challenge is that bacteriophage are very specific to a single type of bacteria. So that there's a phage-bacteria relationship that has to be, and it's quite unique. And then you need another phage for another type of bacteria. So there are challenges in terms of big mass production of phage and saying, I can use this to treat all sorts of infections. You have to have a very bespoke process. Yeah. So that's a challenge. And then in the 1940s, when antibiotics came, penicillin came, it was a single molecule. It could be mass produced. It had great activity against a whole range of bacteria, and it was off-the-shelf product. It was nice and easy to produce. So the interest in phage went away during the early 40s and then through that antibiotic era. And now, of course, with cases like I described at the start of this podcast, we're now realising we need new options, and so the interest has come back. So I think phage is something that is still experimental, and that is why there's not many places around the world that have compassionate use pathways for treatment. The other thing is you need a lot of both laboratory, translational laboratory, and clinical infrastructure set up to be able to do this. Plus, what's the regulatory setting in everyone's countries? That's the regulatory part is a challenge, and we're just working. At least we are with our Australian Therapeutic Goods Administration. We're having workshop interest group meetings to try to resolve what pathway is it? A medicine? Is it a biological therapy? And that changes it. And this is happening in Australia. It's happening, in the US and Europe. And I think they're important hurdles that we need to get over, because unlike producing the single molecule being, the penicillin, we're going to have to produce all different types of phage for different types of bacteria. So are you regulating, which part are you regulating? All the different products? Or are you regulating the production part? And so these are the kind of challenging discussions we're having. But I think our vision is that we are able to offer at this point in time a compassionate use salvage therapy pathway for people who have life-threatening infections where there's no other treatment option. It's experimental. It needs to be where someone doesn't have other options.
And what do you mean by life-threatening infections, such as?
It could be infections, serious lung infections, infections in their blood, infections of other organs.
Yeah.
We also have infections of certain joints and bone that the only way to resolve that is to have an amputation. So if they're life-threatening or limb-threatening, and there aren't any other traditional treatment options, that would fit within our compassionate use pathway.
Okay.
The other part of our vision, though, which is so essential for phage therapy going forward, is to be part of clinical trials. We actually don't have the clinical evidence at this point in time that phage are even effective. We think theoretically they are. We think they are. We see them very effective in the lab. We've got animal models that show they're very effective. We've got case series and case reports from patients that it's effective. But we don't have the rigorous clinical trials that we have for other medicines and antibiotics. And that's the work that we really want to be part of, and I know is happening around the world. And funding agencies are now starting to fund these clinical trials, which is exciting. Yeah. So we're going to see what's going to unfold over the next few years, but we are excited about the science of it and the potential of it.
Okay. So it's a very strict eligibility criteria at the moment to be a candidate for phage. So I suppose the regulatory part needs to be sorted out first before you even think about clinical trials and all of that. Am I correct?
It's a bit different. In a clinical trial, you as long as your product is approved by the regulators to be part of a trial, so in terms of its production, that it's got its production accredited and approved, you can do a clinical trial for something that's not yet approved.
Okay.
As long as there's enough safety data and preclinical data and the production of the product is approved and accredited.
Okay.
So we can do them in parallel.
Sure. So that's phage therapy.
Yep.
And now you've initiated the Superbug AI flagship, which will combine data held in different electronic information systems for the first time. Where are you at this?
Yeah, so I guess
this
is a, we think about what are transformative technologies in medicine that are going to help us with AMR. And artificial intelligence is definitely one of them. And I think that the application of artificial intelligence to healthcare is going to change the way we do things globally. The other is, of course, genomics and microbial genomics, and I think that's a really key another technology that is going to be important for AMR. Our Superbug AI project is trying to bring and unify these transformative technologies so that we are starting to access the entire electronic medical record data of a patient who has an infection with a superbug or an AMR infection. And we're utilising all of their data. When I do a ward round, I take a history, I do an examination, I look at the laboratory pathology results and the radial imaging. I might process maybe 100 to 200 data points in that process. When you look at what's in an electronic medical record of a patient admission, there's probably between 80 to 100,000 data points in the system. Vital signs are taken regularly, all of this data. And you can imagine it's impossible for a human brain to process all of that data to come up with a kind of decision support. So we're utilising the entire EMR or electronic medical record data of a patient with infection plus the bacteria causing that infection. We have their genomes, the genetic information, the genetic code. And we're trying to use both the genetic code of the infecting bacteria and the entire electronic medical record of the patient combined to predict outcomes of that patient, whether that be mortality, length of stay, their need for intensive care, their likelihood of needing to be readmitted or failure from their therapy. So all of these things we're starting, and to do that, we're using machine learning algorithms, which is basically the AI component, and that's called multimodal AI, where we're bringing in, human patient data, the genome data, the imaging, all these components, and we're just at the point now of being able to have models that are able to do that process. So this is version 1. We're very excited by what this may do, because in essence, what we're doing is we're taking entire electronic medical record data to predict patient outcomes, and this could be applied to all sorts of parts of medicine. But for AMR, we're very excited by the idea that we could help decision support for best treatment. What's the risk this patient may transmit their bacteria? What's the risk that if someone's carrying a superbug, what's the risk that they'll develop an invasive infection in the future? All of these factors are starting to now come into our thinking using this technology. It's early days. It's something that we, think that the future will be extrapolated to all healthcare centres that are going to increasingly use electronic medical record data.
Okay, so you'll even have to look at patient movement,
yes,
moving through hospital,
That's right. We're going to be, we're thinking of this, that we've got patient movement, we've got bacteria movement. The antibiotic resistance is a gene. It's a single gene that often lives on a mobile element called a plasmid, and that plasmid can then move between bacteria. So we've got multiple levels that we have to think about now. We've got the patient moving, the bacteria moving, the plasmid moving, and the resistance gene moving between plasmids. So now it's 4 levels, and I don't think we really appreciated the plasmid and the resistance gene moving like we do now. And we've got new sequencing technologies that can give us that resolution, and now we can think about kind of geospatial mapping You can imagine an iPad that you look at each day and you think, oh, wow, I've got hot spots in different parts of the hospital because there's patient movement there with certain bacteria. So early alert systems, much faster response to outbreaks. All of these potentials is what what our vision is and ambitions are.
Yeah, I mean, I can almost imagine it eventually like a flight map in the world, isn't it? These things moving. I mean, because it crosses across, it goes across all countries,
it crosses boundaries
around the world.
It does.
That's a huge problem, Anton. That is not even solving the problem. That's just helping to manage it till we figure out a solution for it.
Yes,
would you say?
I think you're right. I think what our group and what I would say for other groups is to try to use your information when you're understanding the problem. Use that to say, well, what's my action? We can't keep spending more and more time just on understanding the problem and quantifying the problem. We need to then say, how do we use that information to say, what are new solutions? And so an example just then of me explaining the plasmid movement. So now we have to say, well, how do we stop the plasmid movement? How do we stop the resistance gene movement? So we need to do both understanding and action of solutions.
Absolutely.
Yeah.
Okay. And are we doing enough to make a difference, do you think?
I think, as I said, I feel like the last, 5 years, feel like there's really fantastic momentum.
And that's because of greater awareness and
greater
education?
awareness, even though I still think the awareness is too healthcare specific. I think we need greater awareness in the community. So I think podcasts like this are really important to get this message out. And I think that then leads to greater government support, government realisation, resources, and a greater prioritisation of this as as you mentioned, a silent pandemic it's here and now, actually. Yeah. It's not something that we worry about for the future. It's a problem now.
Yeah. And are you looking forward to any particular breakthrough in terms of new medicines, perhaps?
I think, really excited about the kind of alternative therapeutics that are coming through to look at new ways of not only killing a bacteria, but maybe doing other things to it. So one, you might create a setting where it doesn't like a different environment, so it doesn't like to live. So maybe you change aspects and think about our gut health and our gastrointestinal, our microbiome to prevent these bacteria from colonising. The other things about, thinking about how the bacteria make us sick. Can we switch that off? So rather than killing the bacteria, can we stop the bacteria from producing its toxins and nasty molecules?
Yep.
And then, of course, other ways of supporting our immune system, whether that's vaccines or other ways to stimulate our immune system to fight off these bacteria.
Yep. So vaccines do play a role as well in helping.
I think for sure. And vaccines, I haven't mentioned this, but I think the other big part of vaccines, they don't even have to be for the bacteria, even vaccines for influenza and for pneumonia. So other vaccines just generally reduce infections, because we know if you reduce infections, then you reduce antibiotic use and then you reduce antibiotic resistance.
Absolutely.
So I think vaccines and prevention of infection is absolutely essential for AMR control.
Okay. What do you think the future looks like for AMR?
I think the future is that we need to realise that AMR is going to be with us all the time, and it's going to be a journey that we're on, human versus bacteria, and it's about us having the resources, the inspiration, the enthusiasm and the motivation to keep the cause and keep pushing forward on looking for new ways to diagnose, looking for new ways to therapy, looking for new ways to prevent. But I don't think it's realistic to think that we're going to get rid of AMR. AMR is an evolutionary aspect of bacteria which are a core part of our world. So it's about maintaining resources, to stay one step ahead, which I think we can.
Yeah. We will have to coexist, isn't it? There's no
Absolutely.
there's no such thing as not coexisting
That's right.
with viruses and bacteria. It's inevitable.
That's right.
So it was AMR week. It just passed, actually, Anton, 18th to 24th of November.
Yes.
Would you have a message to leave us with?
I think the message is to completely, be aware, engage with this topic. It is something that can impact all of us, our family, our friends, our healthcare systems, and it is so crucial for the functioning of our healthcare. So I would just say, be aware, listen to things like this podcast, and also read and have a think about next time you see your doctor. And you might be asking for antibiotics. Think about the consequences of that. But I think we all have a role to play in the fight against AMR.
Thank you very much for joining us today. Anton Peleg, Professor of Infectious Diseases and Microbiology, Director of the Department of Infectious Diseases at the Alfred Hospital and Monash University, founding member of the Monash Center to Impact AMR. I am your guest host, Meera Sivasothy. This AMR Wise podcast series is brought to you by University Malaya. This podcast series was created by Vedika Bhatt, Professor Sashila Ponampalavarner, ID physician, and Associate Professor Cindy Tay, microbiologist in University Malaya. To learn more about this podcast, please visit our website mentioned below. The recording of this podcast was supported by the Department of Social and Preventive Medicine and the Visibility, Information and Communication Unit at University Malaya. Thank you for listening. Please join us and stay tuned for our next episode. This podcast is supported by a grant from the Foundation to Prevent Antibiotic Resistance. Thank you.